Ma'am, we can start.
Yeah, I think so. Uh, Welcome back to all of you for the second session of today. We had beautiful sessions in the morning by Dr. Ajit Kumar and Dr. C.S. Vanaja. And I welcome you all back and a warm welcome to Dr. Manjula and Dr. Prashant Prabhu, both the speakers who are there with us. Uh, the first topic now is going to be assessment and management of tinnitus, something which we all have definitely come across in our clinics, whether irrespective of whether we are actively involved in the management of the same or not. And to take us across this journey, we have an eminent speaker, Dr. P. Manjula. Madam has finished her UG, PG, and PhD from Ayush Mysuru, and she's involved in academic, clinical, research, and administrative activities at Ayush for greater than 3 decades. Her specific areas of interest include rehabilitative technology, be it cochlear implants and hearing aids, and tinnitus. She has published papers in several national and international peer-reviewed journals. She has co-authored several papers which have been presented at national conferences and has fetched Best Paper awards for quite a few of them. She has successfully completed extramural and intramural research projects and has served as a guest faculty for students of Kelaniya University, Sri Lanka. Over to you, ma'am, for this session on evaluation and management of tinnitus.
Thank you, Deepa. Is the slide visible?
Yes, ma'am. The slide is visible, but your video is off.
Video, okay. The video is on now.
Yeah.
Yes, ma'am. Thank you.
Now, for this topic, that is on evaluation and management of tinnitus is a topic assigned to me. I thank MISHA for this opportunity to share whatever little I know about this topic. So I've just given an outline of this talk here. I'm going to tell you about gender, though all of you, I'm sure, know about this tinnitus, what tinnitus is, and what are the characteristics of tinnitus, and how can we evaluate or manage tinnitus. But I'm going to, maybe you can take this as a refresher session. Okay, so let's go through this journey of refresher program. So tinnitus, the general aspects of tinnitus I'm going to cover, and one model specifically, which usually I use in my clinical routine. I'm going to just briefly tell you about that. And then I will also tell you about some aspects of evaluation. Okay, and then which will include both psychoacoustic and questionnaire or subjective evaluation of the tinnitus, and then the management of tinnitus. Okay, how to monitor the progress in the management of tinnitus, and to 1 or 2 points about prevention of tinnitus. Okay, so now coming to the general aspects of tinnitus, as all of us know. Okay, and it is also well documented that tinnitus is not a symptom, but it is, it is just a symptom and not a disease, okay, by itself. Okay, but that is to say that it is associated with some condition. It could be a Meniere's disease or an otosclerosis where tinnitus can be associated with. It could be a tumor where tinnitus can be associated with it. Okay, it's not a disease by itself. Because it is associated with any of these diseases, many of these conditions rather than diseases. Okay, so the tinnitus has a varied range of expression in different individuals, different characteristics in different individuals. Okay, so it is a tinnitus, as we know, it's a perception of sound within the ears or within the head. Okay, and it is not related to external stimuli at all. Okay, so there is no external source for this tinnitus, and there is no mechanical, the corresponding mechanical vibrations within the sensory organ of the ear. Okay, but it is somewhere within the nervous system that this originates. Okay, And then tinnitus, as Deepa madam already has said, that all of us have come across individuals who are having tinnitus. Okay, and all of us have experienced tinnitus at some point in life. Okay, all of us, even those with normal hearing, have experienced audiometrically normal hearing, have experienced tinnitus at some point of time. Okay, and tinnitus, in general, tinnitus affects about 10 to 20% of the population. Okay, and this is almost the same in the Indian studies also, that it is reported as 15 to 20% of the general population are affected by tinnitus. Okay, so though so many of them are having tinnitus, only about 25% of them, only a quarter of them, they are distressed by tinnitus. That means to say that other persons are having tinnitus, but they're not distressed or they're not annoyed. Okay, but only 25% of them are suffering from tinnitus. They have annoyance, they have distress, they have sleep disturbances. Okay, their quality of life is affected. So in 25% of them who have tinnitus. So we can classify the tinnitus, individuals with tinnitus as either those who experience tinnitus and those who suffer from tinnitus. That is, tinnitus experiencers are there and tinnitus sufferers are there. Among the huge population that is existing, okay, we have tinnitus experiences, those individuals who are not annoyed or distressed by tinnitus, and those individuals who suffer from tinnitus. And of these 20% of the general population who have tinnitus, 25% of them also have hyperacusis or intolerance to even normal sounds in the environment. Okay, so they have tinnitus and hyperacusis is usually related, I mean, coexisting in about 25% of them. So that's the reason the organizers have planned tinnitus and hyperacusis. Dr. Prashant Prabhu will be speaking about hyperacusis. And I also requested him to speak about the cognitive behavior therapy with respect to tinnitus in brief. Okay, because he is undergoing some training by us. Okay, so international expert, he is undergoing training from him. So he will be speaking about the tinnitus and management using CBT or cognitive behavior therapy. Okay, so tinnitus mechanism, to explain that mechanism of tinnitus. Okay, so I should say, and there are many sounds in the environment, and each of these, when we hear a new sound, okay, usually our higher centers will classify this new sounds are either important or relevant to us or not relevant to us. Okay, if the sounds are irrelevant to us, okay, we ignore them, we don't pay attention to them. Okay, so there could be at home, for example, we may have refrigerator noise, fan noise, air conditioning noise. All these noises are there in the environment, but when we have this new system which is generating these noises, okay, our attention gets drawn to it, but later on we usually ignore that noise because it is irrelevant to us or it is not important to us. Okay, some of these slides are there from the earlier talk also. Please bear with me if I'm using the same slides. Okay, as Vanaja said, it's the information, similar information has to be given here also, so I'm using some of those slides here also. Okay, so the refrigerator and fan noise, which are unimportant, we ignore them, though if we pay attention to it, we can still hear that, but we usually generally do pay attention to it. Okay, and then we, for example, the way in which we react to a sound in the environment does not actually depend on the absolute intensity of that stimulus. Okay, that means to say that, for example, if I take this example of sound that is generated by a thunder versus a baby cry. For example, in the night when the mother is sleeping with the baby, she is not awakened if there is a thunder sound in the night, but she is awakened by the cry that the baby cry. Okay, so it is not the absolute intensity that is important. It is the significance that we attach to that particular sound that is important. Okay, so our system is made such a way that we attach different significance. For example, if there is tinnitus, Okay, one person may pay more attention to it, the other person may not pay much attention to it. Okay, so now if we take this model of neurophysiological model, okay, which tries to explain how we associate these different sounds with different non-auditory systems of the individual. Because when we hear sound, it's not just the auditory system that is responding to it. Okay, it's the other systems also which is related to the auditory system or which is interconnected with the auditory system, which are responding to it. Okay, some of those systems with respect to tinnitus, when we take this system as auditory system, there is a sound to the ear, and from the ear or cochlea, it's going to the subcortical pathway and the auditory cortical areas of the brain. Okay, where the signal is perceived and classified as whether it is important or not important. Okay, so if there is a sound in the environment, we, as I said earlier, we classify them as either important or not important. Okay, that is neutral, or sometimes we may associate that with some negative associations. Something like fear can be associated with it. Something like annoyance can be associated with it. Okay, so tinnitus can be like that in some individuals, okay, with negative associations. Okay, so tinnitus, when the sound is heard, okay, when the sound is heard for the first time, for example, this tinnitus again is passing through all these structures. But in individuals who just experience tinnitus and who do not suffer from tinnitus, okay, it will not be passing through the higher centers. Initially, it will pass through and we classify them as irrelevant. And then later on, when it is when it is heard, even when it is heard, okay, we do not pay attention to it because it is not perceived. Okay, and if in a person who's suffering from tinnitus, okay, because he is hearing that tinnitus, okay, he may be getting some sort of a fear, okay, some kind of emotional disturbances can be there in him, because he may think that this tinnitus will cause tumor, or this tinnitus might cause some maybe a deafness. Okay, so because of that, he may get some emotional associations or negative emotional associations, and that is the function of the limbic system. So as I said earlier, it's not just the auditory pathway that is important in hearing this, but limbic system and autonomic nervous system are also involved. Okay, so when there is a fear in the person, okay, there is a heart rate that is increasing. There can be variations in BP, blood pressure. There can be variations in the breathing rate. All this with our functions of the autonomic nervous system also get affected. Okay, when this fear is there, when this annoyance is there. Okay, so in sufferers, this is what is happening. In tinnitus sufferers, the tinnitus that is heard initially gets associated with the limbic and the autonomic nervous system. And then there can be negative associations. And this arrow marks that are shown there are the pathways in which the responses can be seen. Okay, so there can be emotional responses, there can be parasympathetic nerve responses, which can be associated with tinnitus. Now, what we should do in the management of tinnitus is we should break these reflexes or the conditioned pathways. Okay, so if we break these pathways, then we will be successful in making that individual not perceive tinnitus. Okay, the tinnitus is there. Okay, it's something like there is a refrigerator noise, but I'm not perceiving it. Okay, so we have to, in the management, this is what is our goal. We should make that tinnitus irrelevant or neutral. Okay, that will be successful management of tinnitus. Okay, so in habituation of tinnitus, this is what is done. Okay, when there is a tinnitus, we will explain the patient that this tinnitus is not the one that is going to cause tumor, or this tinnitus is not the one that's going to cause hearing loss in a person. Okay, actually, it's a condition that is actually existing with a pre-existing hearing loss. Okay, so with this explanation, we give them some explanations through telling them some analogies and all. with this kind of counseling, okay, we will be paying less attention. Okay, if the person knows that tinnitus is not something that's going to cause some impeding danger, that person is less bothered from tinnitus. Okay, so his reactions, annoyance, he'll be less annoyed, he'll be less distressed, his heart rate is not getting affected, okay, that much. Okay, with repeated counseling and following sessions, the person will get adjusted, in the sense the person is accepting the condition. Okay, so his reaction, his emotional reactions and his parasympathetic nerve responses are all, this pathway is not going to be there. Okay, so when this is not there, he's not going to perceive the tinnitus. Okay, so all these pathways will become irrelevant, or they do not come into picture when we do not perceive tinnitus. Okay, so for example, in this picture on the right side, what I'm depicted is when there is tinnitus, if we consider that as a irrelevant stimulus, okay, irrelevant stimulus or a signal, okay, something like a refrigerator noise, it is not perceived. Okay, this tinnitus is still there, but it is not perceived. Okay, so in experiences of tinnitus, this is what is happening. The tinnitus is not perceived. Okay, whereas in sufferers of tinnitus, they are stressed. Okay, they have, with tinnitus, instead of considering it as not important, they associate with negative associations such as fear and all. And then because of these negative associations, they are stressed, and that becomes a vicious circle, and they are annoyed, and I mean, don't get sleep. It affects their health and all these. Okay, so they become sufferer. Okay, so we have to find out who are the individuals who are just experiencing tinnitus and who are the individuals who suffer from tinnitus. So when we identify them, it's easier. That is important because those who experience tinnitus may not require management. Okay, they may not require management in the sense they have, in case it is associated with a medical condition, something like a tumor and all, they have to get immediate attention, medical attention. However, they don't have to come for an audiological management. Okay, but if the person is suffering from tinnitus, that person will have to, I mean, we have to give management strategies for that individual who suffers from tinnitus. Okay, so in the management of tinnitus, we have to say that for experiences, no management is required, in the sense audiological management or something like habituation and all is not required here, because habituation has happened already there. And in sufferers of tinnitus, management is required. Okay, and in the management of tinnitus, the main goal is to make the sufferers to become experiencers. Okay, so we have to move these sufferers into this category of experiencers. That will be the goal of management of tinnitus. Okay, so but tinnitus can be prevented, okay, when we avoid silence. Okay, so that is what we do when we take sound enrichment into consideration for management of tinnitus. So we should avoid silence, okay, and we should avoid exposure to loud sounds. Exposing to loud sounds can cause noise-induced hearing loss, and this may be associated with tinnitus also. And avoidance of negative counseling. Negative counseling in the sense, nothing can be done to tinnitus. Okay, you have to stay with this condition. Okay, so that kind of a counseling, when we do, the tinnitus problem becomes even more. The problem becomes even more. So we have to avoid such negative counseling. So with provision of sound enrichment or avoiding silence, okay, we can to some extent prevent the tinnitus becoming relevant, I mean, becoming an annoying stimulus. Okay, so now coming to the evaluation of tinnitus. Okay, so tinnitus can be evaluated by both psychoacoustic measurements and questionnaire measurements. Okay, or subjective measures. With psychoacoustic measures, what I mean with respect to specific to tinnitus, there is pitch matching, loudness matching, minimum masking level, and residual inhibitions. These are the measures that can be included in the battery of tests for tinnitus. So with pitch of tinnitus, okay, to find out the pitch of tinnitus, what we do is we will give a series of signals. It could be a tonal signal or it could be a narrowband signal, okay, in different audiometric frequencies we can give to the subject. And then we can find out, okay, if the person has got tinnitus in both ears to the equal extent, then we can test either ear. Okay, if the person has got tinnitus in one ear and there is no tinnitus on the other ear, okay, you can test in the non-tinnitus ear to assess the pitch tinnitus and all. Okay, so when you're finding out the pitch of tinnitus, you will have to give these different stimuli to the ear and find out to which of these signals the tinnitus matches with respect to the pitch. Okay, so that way you can use different methods like two alternate forced choice method, or you can give single frequencies and find out whether those signal frequencies match with that of the pitch of tinnitus. Okay, and then with loudness of tinnitus, we have to consider the signal that with which the pitch is matched, and with that, for example, if the patient says that at 2 kilohertz the pitch is matching, so we will take the 2 kilohertz narrowband noise and starting from a level below the threshold, okay, go on increasing the level, find out the threshold of that signal, and then go on increasing the levels and find out at what level this 2 kilohertz narrowband noise is similar to the loudness of its tinnitus. Okay, so this is a very important measure. That's because even though the person is very much distressed with tinnitus, okay, the person is not, that is not related to the loudness of tinnitus. Okay, so when I say loudness of tinnitus, it is the level at which he matches the tinnitus minus the level of his threshold. For example, at 2 kilohertz narrowband noise, if his threshold is 20 dB, and if he matches his loudness at about 35 dB, okay, you will have a 15 dB of tinnitus. That 35 dB minus 20 dB, which is the threshold, is the loudness of tinnitus. Okay, so loudness of tinnitus here is in terms of intensity. Okay, so that is the loudness of tinnitus, and minimum masking level is that we will find out what is the minimum level of this 2 kilohertz noise that is required to mask this tinnitus. Okay, at different frequencies, we can find out the levels at which the tinnitus gets masked. Okay, there is also one measure called residual inhibition, in which what we do is we give a broadband signal at about 10 dB SL. The different proponents say different levels. Some say 10 dB SL with reference to the threshold of that broadband noise. Okay, give 10 dB above that level for 1 minute. And after giving that sound, the person will have to say whether the person is still perceiving. After we stop this 1 minute of noise, the person will have to tell us whether he is still hearing the tinnitus, or the tinnitus has stopped, or the tinnitus has reduced, or the tinnitus has increased. So these are the 4 kinds of responses that we may get, okay, when we do this residual inhibition test. Okay, that is a positive complete, we say, when the tinnitus is not heard soon after the cessation of the broadband signal. Okay, that is positive complete. Another one is positive partial, where you have the tinnitus is reduced to some extent, okay, soon after the cessation of the broadband signal. And then the other condition is there is no change in the amount of tinnitus. The tinnitus is same as that it was before. Okay, so that is negative condition. And then we have a rebound phenomenon where the tinnitus increases. Okay, so all these are done. This is not, I don't consider all these measurements are very important. This is important to the extent to say that this tinnitus is existing in you, okay, in a patient where the tinnitus is main complaint. Okay, we can measure that aspect. That means to say that something is there in his ears or something is there in his head, okay, that the person is hearing, that we can measure. Okay, so that itself reassures a particular person, saying that there is something existing. It's not that he is possessed by a devil, or is not that he is possessed by something evil. Okay, so that kind of a notion many of them have. Okay, so and then there are other audiological evaluations, the routine audiological evaluations like pure tone testing, speech audiometry, loudness discomfort level. Loudness discomfort level is important in the test battery of tinnitus evaluation. That's because it's sometimes, most of the time, as I said earlier, 25% of the time, tinnitus, those who have tinnitus also have hyperacusis. Okay, and emittance evaluation is also included in this. And provided reflex, when you're testing reflexes, you will have to be careful that the person, because some people may have hyperacusis. Okay, so you may not have to do reflexes in such individuals because reflexes are usually done at higher levels. OE evaluations are done and ABR and LLR evaluations are done. These are all, and extended high frequency audiometry is also can be included. I'll tell you a study in which we found some significant findings. Okay, and in the subjective measures, we have different questionnaires. Innumerable number of questionnaires are available. Something like tinnitus handicap inventory, the screening version and the long version, and then the tinnitus functional inventory. Okay, all these different questionnaires are there. These are more important than these psychoacoustic evaluation measures. That's because this is the one which tells us about the severity of the problem. Because as I said earlier, you can have two individuals having the same loudness. They may have 15 dB of loudness of tinnitus, but one person may be annoyed with tinnitus. Okay, that is identified only with questionnaire, not with any of these psychoacoustic measures. Okay, the annoyance or distress that is caused by tinnitus can be measured with questionnaires. So questionnaire testing should be an integral part of evaluation of tinnitus. In one of the studies conducted by Sriraj in 2017, okay, so this was his doctoral thesis that was done. He took individuals with tinnitus and without tinnitus, but both the groups were having normal hearing. So those individuals with normal hearing, with and without tinnitus, he had taken and he did all these different audiological tests, pure tone thresholds, speech recognition thresholds, speech identification scores, okay, emittance evaluation, okay, extended high frequency thresholds, okay, and then the subjective evaluation of tinnitus, the pitch, loudness, okay, the psychoacoustic evaluation of tinnitus, sorry, pitch, loudness, residual inhibition. And then he also did the ABR, LLR, all these different testings was done. The psychoacoustic tuning curves were also done. It was seen that in none of these audiological tests, there was significant difference between the two groups, that is with and without tinnitus. Though there were some differences in the absolute value. For example, with ABR, the peak 1 latency was delayed, or in LLR, P1 latency was shorter and amplitude was higher in those with tinnitus. Okay, but these were there, but it was not, the group data did not show any significant difference between the groups. So this is not the one that differentiates those with and without tinnitus, but you can see some of these tests, such as extended high frequency audiometry, 10 kilohertz to 16 kilohertz when the thresholds are plotted. This is the group with normal hearing. Okay, even with normal hearing, when the thresholds with normal hearing, up to normal hearing up to 8 kilohertz was the criteria when these subjects were chosen. And these are the thresholds that were obtained for individuals with tinnitus. Okay, so like this, we have different, the audiometric configurations, okay, can be similar. The audiometric results can be similar, but extended high frequency audiometry, when it is done, there can be a difference. Okay, so with pitch, loudness, residual inhibition, as I said earlier, no relationship between the psychoacoustic evaluation and the severity of tinnitus. There was no relationship between these conditions and the improvement in tinnitus. Okay, so that way, this was not correlated with any of the severity of tinnitus, or the outcome of management was not correlated with any of these. Okay, so that means to say, these are all related to the auditory system. Okay, so these are all related to the auditory system. When we say that these are not correlated with the severity of tinnitus, or it's not correlated with the outcome of management, okay, so that means to say that the auditory system is not very crucial in finding out the severity of tinnitus or in measuring the outcome of management. Okay, there are other systems that are responsible. So other systems, as I said earlier, the limbic systems, the autonomic nervous system, and all are involved in the tinnitus. Okay, so that will give you a more clear indication with when you use subjective rating scales or subjective questionnaires. Okay, there's another question done by Makkar et al. 2009. Okay, where he found that 60% of the patients, okay, 60% of the patients having tinnitus, the pitch did not fluctuate much. The pitch was almost the same over time. But in 74% of the, the 74% of the persons with tinnitus, there was no fluctuations in pitch. And in 68% of them, the loudness was slightly fluctuating. Okay, some of them during the night, they found that the loudness was more. And some of them, and those individuals who had loudness more at the night time, they perceived it softer during the daytime, something like that. So, and you have questionnaires such as tinnitus handicap inventory and tinnitus functional inventory, as I said earlier. And these psychoacoustic characterization were similar in experiences and sufferers. Okay, this was the one which differentiated the experiencers and sufferers. Okay, these questionnaire scores. Okay, this is one example of a questionnaire where you can administer this questionnaire, and then you can get the total score after administering the questionnaire. And based on the total score, tinnitus handicap inventory, those are the total score, we can classify the severity of tinnitus as either slight or severe or moderate, depending on the scores, which range from 0 to 100. So that's about the subjective evaluation of tinnitus, using the subjective evaluation of tinnitus, which is more relevant or more important than the psychoacoustic measure, okay, which will tell us about the severity of tinnitus, and it will also tell us about the outcome measures, whether the outcome measure is effective or not. This is the subjective evaluation is the one that's going to give us information about. Okay, so now after the evaluation of tinnitus, the management of tinnitus, there are various forms of management, because there are lots of teams of, there are different professionals who are involved in treating the tinnitus. Okay, all these different forms of treatments are tried. The dietary restrictions, such as reduced intake of caffeine, reduced intake of salt, and things like that. So dietary restrictions are tried. Medications are tried. Okay, you have surgery sometimes when the ear has some other problem. When surgery is done for that problem, there is instance of reduction in tinnitus. Okay, so the psychological ways of therapy is also included. Cognitive behavioral therapy, relaxation techniques, and other psychological measures are used for therapy. Music therapy is also used. They use notch music. So that means to say, when if the tinnitus is tonal, in that particular tone, they remove the from the music, they remove that particular frequency to create a notch in that music, and then they expose that signal to the individual. Okay, and then some of the studies have found that to be useful. But some of these dietary restrictions medications are all not evidence-based, or they need a lot more evidence before we try it on our subjects. Okay, and there are alternative therapy forms also which are tried, such as acupuncture, homeopathy. All these several forms of therapies have been tried, but more evidences are required. So as audiologists, we've seen that we've used masking, tinnitus masking. Okay, but now recently of late, instead of using the term masking, we call it suppression, tinnitus suppression. Okay, because with masking, we assume that the tinnitus signal is completely masked with the external signal. Okay, so that shouldn't happen, because if that is done, if you remove the external signal, the tinnitus is still perceived. Okay, but when you use suppression, that is, the level of the masker should be slightly lesser than the level of the tinnitus. Okay, so if that is done, then when that is called suppression. Okay, with suppression, habituation is facilitated, and there can be, there can be improvement in reduced perception of tinnitus. Okay, So masking term we shouldn't use now. I mean, with the latest literature, that is what is given. We can use tinnitus suppression instead of tinnitus masking. When you're using tinnitus suppression using an external signal, the external signal should not be frequency specific. It should be as broad in frequency as possible. Okay, it should be like a broadband noise suppression. Okay, and it has to be partial suppression, not total suppression. Okay, and sometimes the hearing aids also have helped to reduce the perception of tinnitus. That's because when we give the hearing aids, okay, these individuals who have hearing loss, okay, usually will not be perceiving the external environmental sounds. But when a hearing aid is given to them, the external ambient sounds are also amplified. And these are the sounds which may help in suppressing the perception of tinnitus. Okay, so it promotes habituation. Habituation, I'll explain later. And when you're giving hearing aids for the 2 years, okay, if you have to give it binaural hearing aids. Okay, if the hearing loss is there in both ears and if it is associated with tinnitus, binaural hearing aids are to be given. Okay, even if it is not associated with tinnitus, we advise binaural hearing aids. Okay, and hearing aids with open ear moles or vented ear moles would be better for them, because when the ears are blocked, they perceive it more. Some of them complain of perceiving it more. Okay, and if the noise reduction strategy is enabled in the hearing aid, then it may not help that much, because those are the noises that the person with tinnitus will have to hear.
Excuse me, Dr. Manjula, there seems to be some issue with the audio. We can't hear you.
She has gone to mute, I think. Mute button is on.
Yes, ma'am. Could you unmute? Could you say something? No, we cannot hear you yet.
Some symbol which is popping up there.
No, that is
See?
a spotlight. That I've put her in spotlight. Would you like to disconnect and reconnect your audio? We cannot hear you. If it's okay, maybe if you want, you could log out and re-log in. I'll make you a co-host again. We will get her back in a minute, and yes, we will request her to start at noise reduction strategies. Okay, ma'am, we've got you in, and I've just made you the co-host.
Can I switch off the video?
Sure, sure.
Thank you.
And ma'am, we request you if you could restart at the noise reduction strategies.
Yeah.
Thank you so much.
Can you see that slide?
Yes. But are you on 2 devices? Because there
Let's
is
switch
no.
off the other one.
Yes, please.
Yeah.
Yes.
So I thought I'll do my audio from my mobile phones, but this got
Yes.
disabled. Okay. So when I was telling you about the hearing aids which are used to manage tinnitus, okay, those individuals who have hearing loss can be helped by this. Okay, and in hearing aids, we also have noise reduction strategies or noise reduction algorithm, which reduce the environmental noise. And this reduction of noise in the environment. Okay, so actually, when I was telling you about prevention, I would say, I was saying that the sound enrichment has to be there. We should avoid silence and things like that. So with noise reduction, okay, there is suppression of this noise. Okay, that may not facilitate habituation, or that may not help in reduced perception of tinnitus. So only when it is required, the noise reduction strategy could be enabled. At other times, it can be disabled. Okay, and then like coming to the devices that are available, there are specific dedicated sound generators which are available, and combination instruments which combine both hearing aids and sound generation. And there are several mobile apps that are available. Okay, so now the trend is more towards using mobile apps rather than using the combination instruments, because for combination instruments we have to pay extra, but mobile apps are freely downloadable, most of them. So when there is direct streaming with mobile, the hearing aid is directly streamed with mobile, these mobile apps can be useful in such situation. In coming to the actual management aspect, okay, there are actually 2 phases in the management of tinnitus: counseling and habituation. There are several forms, but I'm going to highlight only this aspect, that is counseling and habituation, because in the time that is given, we can't cover all the systems of management of tinnitus. So I'm going to highlight only on this aspect. Okay, so tinnitus retraining therapy also uses counseling and habituation, but the tinnitus retraining therapy that was proposed by Jastreboff, okay, also uses direct counseling and sound therapy. And counseling, when the role of counseling in the management of tinnitus is that, so what we have to do is we have to reverse the feedback loops. I was telling you with the neurophysiological model of tinnitus, okay, there is a feedback loop that is from the subcortical centers and from the cortical centers. There is a loop that is connected to the limbic system and the autonomic nervous system. So these loops have to be weakened, or it has to be reversed. Okay, so this retraining we have to do with the help of counseling. This can be done easily with the help of counseling. And when we use this, saying that auditory, limbic, autonomic and all, these are all scientific terms or medical terms. It will be difficult to explain these individuals who have tinnitus using these terms. So using some analogies or stories, we have to retrain them or reverse these feedback loops. Okay. These individuals who suffer from tinnitus will be having negative thoughts, or they'll be having anxiety in their mind, which is associated with tinnitus. We have to demystify that or reclassify this tinnitus and make it into a tinnitus which is not perceived. Okay, so in the management of tinnitus, we should remember this, that tinnitus can never be cured. Most of the instances, it's there, but the reaction to tinnitus or the perception to tinnitus can be managed. Okay, so when I say demystify tinnitus, this can be done through counseling. We can remove the negative thoughts by explaining what tinnitus is, what is it associated with, is it causing hearing loss, or is tinnitus caused by hearing loss? All these factors needs to be explained to the tinnitus. This is what we do here in our institute also. And we also remove their belief. If they have some belief saying that this is leading to some catastrophic event in the future or something like that, we have to remove that belief from them through counseling. Okay, and most important thing is we should tell them, we shouldn't tell them that nothing can be done with this. Okay, we shouldn't tell them that they have to live with this. Okay, though when I say that tinnitus cannot be reduced, tinnitus is like that only, or tinnitus cannot be cured, we shouldn't say that. We should give them management strategies to them. So during counseling, we reclassify the tinnitus to a category of neutral signals. Okay, that is something like a signal like a refrigerator noise or a fan noise or an air conditioner noise. Okay, in this example, when counseling, okay, so we can use this example. Okay, if I am going, if I'm on a holiday and gone to a hotel for accommodation to stay there for about 2 days for sightseeing and all. Okay, so supposing I hear a hissing sound in the night. Okay, that entire night in that hotel or in a resort, I will not get sleep thinking that it could be a snake. Okay, so now, and the next day when I check with the front desk person, so he tells me that this is not a snake, that that sound is because, okay, there is a nearby petrol bunk in that the air pump is leaking, so that's the reason there is a hissing noise. Okay, so with that explanation from him, the next day I'm going to sleep well. Okay, that way that fear is removed from me. Okay, so I'm reclassifying this sound. This sound is not dangerous. Okay, so this sound is not causing any problem. So with that reclassification, I'll be going to good night's sleep there. So that way, if that is one example, and here there is another example where for example, when in a classroom, if I'm teaching students, okay, so in that classroom, if there is a tiger in the corner of this never happens, but this is just an imaginary example. Okay, so if there is a tiger in a corner of the classroom, and even when I say these students that this tiger is not harmful, okay, it is tamed, okay, it will not harm anyone. It has not harmed anyone in earlier days also. With all that advice, okay, with all that speeches, the students are still having that kind of attention in them. They will not pay attention to what I say, okay, in the class. Okay, they if I give a lecture, they will not be listening to me. That's because they have that fear in the corner of, not in the corner of their mind, in their mind. Okay, so this fear we have to remove. The tinnitus is like fear, like the tiger now. Okay, so in the person who is suffering from tinnitus, this fear is there in their mind always. So we have to remove that fear in the sense we have to tell them the tinnitus is not a danger signal. Okay, it's a harmless signal. Okay, so it is a sound like a refrigerator signal. So after 2 days, we don't pay attention to that refrigerator signal at all. Okay, so we have to classify that tinnitus so that it becomes a neutral signal and we do not perceive that. Okay, and here that's about the counseling that we use in tinnitus. Now about the habituation that we use with tinnitus in the management of tinnitus. The signal, okay, when we perceive a particular stimulus in the environment, we perceive it based on the contrast that is there in the environment. For example, when you perceive this candle light, okay, if there is a dark background, we perceive the brightness of the stimulus. But the same candle that is there in the daylight, for example, with this kind of a daylight background, this brightness is not perceived that much. Okay, so the contrast is the one that has helped us in perceiving, okay, whether the candle is there or not. Okay, so this is what should happen with the tinnitus. So when there is a tinnitus, if there is an environmental noise, for example, if in this graph, when I have a tinnitus like this, if there is a background noise, if background noise is very less, then I will still perceive the signal. In the contrast between the tinnitus and the background noise is more, that's why I'm perceiving it. Here it is like this. The contrast between the background and the brightness of the light is more, so that's why I'm perceiving the brightness. Here I'm perceiving the tinnitus because the contrast is more. Here, when I increase the background, the tinnitus is less perceived, like this in this example. Okay, so that is what we should do with sound enrichment. So we should avoid silence so that there is background noise in the environment of the patient. So that will help him to perceive the tinnitus lesser. Okay, so that is called sound enrichment, sound therapy, and it's called by various names. Okay, that can be used for habituation. Habituation can be achieved through sound enrichment or through some other forms like progressive tinnitus management and all. So there are several ways of achieving habituation. Sound enrichment is one way. Okay, when you use that sound has to be neutral. It shouldn't be any emotion evoking stimulus. Okay, it should be a well-controlled, stable source also. Okay, the amplitude shouldn't be too much varying. That's the reason a broad spectrum, a white noise sort of a thing will be more useful. Okay, it shouldn't be annoying. Okay, it should be binaural. All this have to be followed when we are using sound enrichment for, and the level of the sound should be such that it is just below the level of the tinnitus. So, and also this is the mixing point graph that is used to explain what should be the level of sound enrichment. Supposing in this graph, the y-axis indicates habituation. Okay, higher the level, higher the habituation. Okay, and here on the x-axis, it is sound intensity. Okay, so when there is tinnitus, as we increase the sound enrichment intensity, okay, habituation is increasing. Okay, that is we have less and less perception of the tinnitus. But at a particular point of intensity, the tinnitus is masked. Okay, then habituation is not happening. Habituation reduces. If you further increase the intensity of the sound, then habituation reduces because masking of the tinnitus is happening. That's why I said masking shouldn't happen. It should only be suppression. Okay, so the level of sound enrichment should be just below this level of intensity. These levels, okay, just below the mixing point should be the level of sound enrichment. Okay, so this habituation can be facilitated by using the sound enrichment and counseling, medication, and other forms of therapies also. So as I said earlier, we should all realize that there is no cure. I mean, majority of them, there is no cure for tinnitus, and it is only habituation of reactions and habituation of perception that we should aim at. Okay, those in that neurophysiological module, okay, model, you have the feedback loop, which is connecting the autonomic nervous system and limbic system to the cortical and subcortical structures. Okay, that is the loop that is removed, okay, by habituation. Okay, so this will allow the patient to cope well with tinnitus and to participate well in the day-to-day activities. So that way, this kind of a thing will help. If it is associated with hyperacusis, then use of habituation can be used, or progressive desensitization can be used, and even cognitive behavior therapy can be used. Some of these can be used, but hyperacusis has to be treated before you manage tinnitus. Okay, so with this, I mean, this habituations will take some time. It may take about 12 months, okay, about a year, and in some cases it may take up to about 18 months or 24 months. But it is worked for majority of our patients that we try here. So monitoring has to be done every month by administering the audiological tests and the questionnaires. Every month it is done for the first 3 months of management, and after the 3 months, that is from 4th to 12 months, we have to monitor it. Maybe once in 3 months or once in 6 months we can monitor. Okay, and for while monitoring, psychoacoustic measures as well as questionnaire measures have to be done, because only in the questionnaire measure you will find improvement. With psychoacoustic measure you may not find any change. So you will have to administer both of them, and in questionnaire there can be a reflection of improvement. Okay, so that is about the tinnitus evaluation and management. Mainly counseling and sound enrichment as part of management is what I think for. That's it. Thank you.
Thank you so much, Dr. Manjula. for this very interesting lecture. Ma'am, we are going to have a talk on on hyperacusis now.